Good afternoon, everyone, and welcome back to BSN620. This is week 5, and today we're going to be learning about psychotropic medications. So in the past few weeks, we've been talking about some of the different factors that can cause an individual to have a mental health disorder. We've discussed several factors like genetics, neurodevelopmental factors, drugs, your psychosocial experience. These can either work alone or in combination with one another. And today I wanted to mention a little bit about biopsychiatry. So this is a theoretical approach that states that mental health disorders are a result of biological malfunctions. So here we're saying that these abnormal changes that are happening to a client's behavior, their mental and emotional experiences, these are caused by disturbances in normal brain function. So we're saying that when the brain is not working as it should, the way that it produces and responds to neurotransmitters, that's going to change. And then these changes can result in symptoms of mental health disorders like depression, anxiety, PTSD, or any other combination of environmental, behavioral, emotional, mental health disorders. So if we're using this approach, then we're pretty much saying that the goal of drug therapy is to restore this quote unquote balance to this malfunctioning brain. And the medications are going to help with this. In regards to this biopsychiatry approach, the full understanding about how different medications work to support and treat symptoms, it's still elusive. There are some theories, but we don't fully understand how the mechanism of action for all of these psychotropic drugs actually work. And that's because there's a large number of neurotransmitters, hormones, and other co-regulators that actually play an important role, and these are very complex roles. So this is just a review of the functions and the activities of the brain, and we're just reviewing this because a lot of this is going to come up in the symptoms of different mental health conditions, right? We're going to see that clients might have difficulty with their social skills, with their memory, with different cognitive abilities, even movement, with their sleep and wakefulness cycle. So this is just a review of the different functions and activities of the brain, because this is going to come up when we are talking about the symptoms. And also when we're talking about the different medications that are targeting the different areas and hence are targeting the different type of symptoms related to each mental health disorder. And as I mentioned, there are different theories about and different factors related to disturbances of mental function. So we've spoken about how your environment, your genes, this can have an impact on you having the risk of developing a mental health concern. When it comes to neurons and neurotransmitters, some of the ones that we're talking about are listed here. And some of these are going to be a review as you have learned about them in previous courses. But just wanted to give a, overview just so we remember. With norepinephrine, this usually regulates our alertness, our attention, our stress response, and even our mood. So if there is some sort of disturbance with norepinephrine, so if we have low norepinephrine, oftentimes we might see symptoms of depression. We might see low energy, poor concentration, even decreased motivation. If we have excessive amounts of norepinephrine, we might have symptoms of anxiety, There might be mania, even hypervigilance, irritability. With serotonin, we might remember that it also helps with mood regulation. It also helps with our appetite, our sleep, our impulse control, even our pain perception. So, if there's a disturbance in the amount of serotonin that's available, that can also have an impact on our mental functioning. If there is decreased serotonin, it's also hypothesized to be linked to depression. So, feeling extremely sad for long periods of time. Um, Decreased serotonin has also been hypothesized to be linked with symptoms of anxiety, um, and even sometimes impulsivity or suicidal ideation. Dopamine, we should know, is associated with the reward and the pleasure pathways in our brain. So it really helps with motivation, as well as even our movement and cognition. So if there are disturbances in our dopamine, that can also impact our mental functioning. So in general, when we learn about schizophrenia in a couple of weeks, we'll learn about the dopamine hypothesis, which is saying if there is an excess amount of dopamine in the brain, it can result in some of the positive symptoms that we see in schizophrenia. So the hallucinations, the delusions. On the other hand, if there is decreased amount of dopamine, that can also result in the negative symptoms that we see with schizophrenia, which we'll learn about. So this is the apathy, the lack of motivation, the flat affect. And today we're also going to learn about something called EPS, the extrapyramidal symptoms. This is also hypothesized to be related to low levels of dopamine as well, because as I mentioned, dopamine is also responsible for our movement. And as we'll learn today, extrapyramidal symptoms have to do with a movement disorder. And so on and so forth, right? So essentially the point we're trying to make here is that there can be disturbances in our mental functioning when different neurotransmitters either are excessive in our brain or there are low levels in our brain. So now we're going to get into different psychotropic medication classifications. And as we learn about the different diagnoses, we're going to come back to these psychotropic medications. So next week, when we learn about anti-anxiety, or rather anxiety and stress disorders, we'll review anti-anxiety medications. When we talk about depression and other mood disorders, we'll review antidepressants and other mood stabilizers. So the type of psychotropic medications that we're going to talk about today are going to be the anti-anxiety medications, antidepressants, mood stabilizers, as well as antipsychotic drugs. So we will be learning about anxiety very specifically next week, but just as an overview, anxiety is a group of mental conditions that is characterized by excessive fear or apprehension about either a real or a perceived threat. And this can lead to altered behaviors. And there are physical symptoms that are also associated with anxiety, such as increased heart rate and even muscle tension, stomach ache, sometimes even diarrhea. But we'll learn more about that. But just for now, you should know that anxiety is this unpleasant state of mind that is characterized by this sense of dread and fear. And this could be based on anticipated experiences or actual experiences. And we also have insomnia. So this is a sleep disorder where it's difficult to either fall asleep or stay asleep. And sometimes if you have anxiety, you might also have insomnia. which is why we've placed them together here. And also because some of the medications that we're going to learn about now can also be used for both situations, anxiety and insomnia. So anxiolytic drugs are also known as anti-anxiety medications. So these reduce anxiety by reducing the overactivity in the central nervous system. So we're going to be talking a little bit about GABA, which is the gamma aminobutyric acid. So this is a neurotransmitter, and it's called a inhibitory neurotransmitter because it produces a calming effect. So it reduces nerve cell excitability and it has a calming effect on the brain. If there is a disruption in GABA, this is often linked to neurological or psychiatric conditions like anxiety, epilepsy, and even sleep disorders. So GABA, it usually acts as the brain's primary inhibitory neurotransmitter. Okay, so it's supposed to create a sense or a state of calm and balance. So when the GABA signaling is unbalanced, then we have this excitatory signal or this loss of inhibitory control. And this is what manifests as increased anxiety, as mood disturbances, as sleep problems, even sometimes seizures. So in the case of epilepsy, right? And drugs that excite GABA, they cause a sedative hypnotic effect on the brain. So with the sedative effect, we're talking about that calming effect, and with the hypnotic effect, it's the ability to induce sleep. So benzodiazepines, these are one of the classifications of anti-anxiety medications that are commonly used. So when you think about benzodiazepines, think about the PAMs and the LAMs. So as you can see, some of the examples here, we have diazepam, clonazepam, right? Lorazepam, alprazolam. So the PAMs and the LAMs. So benzos end in lam and pam. That's one way that you can remember the medications. And the benzodiazepines essentially depress activity in the brainstem and the limbic system. And they produce that calming effect. So they're also associated with physical tolerance, dependence, and the potential for misuse. So when we're talking about tolerance, we're really referring to the body getting used to taking a substance, even a medication, and you requiring higher doses to achieve that therapeutic effect. Whereas dependence, here we're really referring to the physical or the psychological symptoms that occur that make you feel like you have to continue taking that substance or that medication. So these medications have the potential for both the physical tolerance and dependence, and even the potential for misuse by the client. And for those of you that had me for pharmacology, you would remember that benzodiazepines make your vitals go low and slow. So when you think about anti-anxiety medications, especially benzodiazepines, think about the vital signs going low and slow. Even with the CNS depression that we have, everything for the client is going to go low and slow. So it's that calming effect, right? So typically there's a lower heart rate, lower breathing, right? So there's that calming effect that we do want, with a client that is experiencing anxiety, right? In regards to benzodiazepines and the adverse effects, they're they're pretty much the overexpression of their therapeutic effect. So we're going to see decreased CNS activity. We might even see the client feeling a little bit sedated. They might even have some amnesia. There might even be some hypotension, so that low and slow. They might experience some drowsiness, loss of coordination, even dizziness and headaches. They might also even experience nausea, vomiting, dry mouth, and constipation. This slide pretty much is listing the 6 benzos that are used to treat insomnia in Canada. And they do have that hypnotic effect, so meaning that they induce sleep. So they are supposed to help the client either fall asleep or stay asleep. And in general, at high doses, all benzodiazepines can cause sedation. And if you use benzodiazepines at a lower dose, for example, lorazepam, or even what's the other one? Alprazolam, which was previously listed, they can reduce anxiety without inducing the sleep aspect. Then we also have the Z hypnotics or the Z hypnotics. These are short-acting sedative hypnotic sleep agents. And they're called the Z hypnotics because there's 3 medications that start with the letter Z. So one of them is zopiclone, also known as Imavane. There's also another classification of a medication that's called buspirone. So this differs from benzodiazepines because it's non-sedating and it's non-habit forming. And typically with benzodiazepines, you can give them on a regular schedule, but clients can also take them as a PRN when they feel that their anxiety is becoming a little bit more challenging to manage. They can take the medication as needed. However, with buspirone, it's given on a scheduled basis. So the main difference between this and the benzodiazepines is it's non-sedating and non-habit forming, and it's given on a scheduled basis. And we're going to talk about antidepressants coming up, but we can also give selective serotonin reuptake inhibitors, SSRIs, at certain doses for anxiety as well. And that's because the symptoms, the neurotransmitters, and even the circuits that are associated with anxiety disorders, they do overlap with those of depressive disorders. So many drugs that are used to treat depression have also been proven to be effective treatments for anxiety disorders as well. And SSRIs are one of them, which we'll learn about coming up. So when it comes to the nursing process for anti-anxiety medications, of course, we have to, start with the assessment of the client. So here we are assessing, of course, as I've been mentioning, we're not forgetting about the physical aspect of the client, right? So of course, we're always taking the full physical history, their vitals, but we're also assessing the client's anxiety levels. So how long have they had anxiety? What does their anxiety manifest like? Is it psychological? Is it physical? Is it a combination of the two? What are their coping strategies? What are their triggers for their anxiety? When they do feel anxious, what are the things that help them? What are the client's sleep patterns like? Because sometimes anxiety and depression can go hand in hand, not always. And if you have anxiety, sometimes your sleep can be impacted. So How often and how well is the client sleeping? How much sleep are they getting per night? We're also assessing for any substance use history, right? So is there a risk for misuse with benzodiazepines? In terms of the diagnosis, so here we're really trying to figure out how is the client responding to their symptoms or diagnosis, and how are they managing, right? So these are just examples, right? So is there a risk for injury related to CNS depression, or sedation or impaired coordination because of the use of anti-anxiety medications, right? Because as mentioned, it makes everything go low and slow. So clients might be feeling a little bit dizzy, drowsy, sedated. So they might have a loss of coordination. So is there a risk for injury? Is there a risk for dependence related to long-term benzodiazepine use? Is there ineffective coping related to their anxiety, for example, right? With planning, we really want the client to be able to verbalize decreased anxiety. We want the client to use non-pharmacological interventions in addition to anti-anxiety medications as well, right? And we'll talk more about those when we talk about anxiety next week. In terms of interventions, with benzodiazepines, right, we want to monitor for sedation, for dependence, for even withdrawal. With buspirone, as I mentioned, this is more on a scheduled basis, but we also have to educate the client that there is a delayed onset. Usually, it can take 2 to 4 weeks for the effects to kick in. Whereas with benzodiazepines, there is a rapid onset and duration of action. So there is significant symptom relief that the client gets when they do take a benzodiazepine. But of course, we do have to start at the lowest dose for the shortest period of time. So of course, we have to teach the client to avoid alcohol and other CNS depressants. So when it comes to benzodiazepines, overdosing on benzodiazepines is rare. However, if you are taking benzodiazepines and you take other CNS depressants, such as alcohol, opioids, or other CNS depressant medications, that can increase your risk of overdose. So of course, educating the client not to drive because of that risk of drowsiness and dizziness and sedation, encouraging the use of relaxation techniques along with medications, which we'll talk about next week. And for older adults, we do have to monitor for oversedation and even profound CNS depression. In terms of evaluation, we're trying to monitor to see, are there reduced symptoms of anxiety? Is there an improvement in the client's daily functioning? Are they able to use coping skills in addition to their medication? And we're also evaluating for any signs of dependence, misuse, or withdrawal. And of course, we are monitoring for the therapeutic effects of anti-anxiety medications. So is there improved mental alertness, cognition, and improvement in the client's mood? Are they experiencing fewer anxiety attacks? Is there an improvement in their sleep and their appetite? Do they feel less tense and irritable? Are there fewer feelings of fear or impending doom? Is there an interest in their self and in others? Because as we're going to learn about next week, there can be a lack of motivation. There can be anhedonia, so a lack of interest in activities that the client previously used to enjoy. So we're monitoring to see are the therapeutic effects of the anti-anxiety medications showing up for the client. So next we're going to talk about depression and antidepressants. So once again, we'll talk in detail about depression in the coming weeks, but for now, we should know that depression is a persistent feeling of extreme sadness or depressed mood that lasts for a minimum of 2 weeks. And there are many factors that are linked to depression. There can be genetics, there can be psychological and even social and environmental factors, right? So, do you have a supportive family and friend circle? Are you lonely? Are you isolated? These can increase your chances or your risk of depression. Chronic stress, trauma, right? Your home environment, all of this can have an impact and are factors linked to depression. Even your brain chemistry. So when we talk about depression in the next couple of weeks, we're going to talk about the monoamine hypothesis. So this theory is suggesting that when there is a deficiency or this underactivity of monoamine neurotransmitters, which are serotonin, norepinephrine, and dopamine, this plays a role in the development of depression. So what's really interesting is that in 2021, Canadian pharmacies dispensed approximately 64 million antidepressant prescriptions. 64 million prescriptions. That is a insane number. And that was still 4 years ago. So who knows how high the numbers are actually now. So when we're talking about antidepressants, we're going to be talking about first generation as well as second generation antidepressants. So with first generation antidepressants, these essentially work by correcting this so-called imbalance of serotonin and norepinephrine. And these are, at one point, these were the first line of treatment. However, these have now been largely replaced by SSRIs, which are the second generation. So now when we are prescribing antidepressants, the first line of treatment is second generation antidepressants, not the first generation. And the reason for this is because first generation antidepressants have many adverse effects. They take longer to reach optimal dosage, and there's also a high potential for lethality, which we'll talk about. And for that reason, these are considered second line drugs. So first generation antidepressants are still prescribed, but they're just not the first line of treatment. They're usually reserved for clients that maybe they have atypical depression, or for clients where the SSRIs or other newer generation antidepressants are not working as well. And they can also be used in combination with the newer generation antidepressants. So like I said, they typically work by correcting this imbalance of serotonin and norepinephrine. So once again, with norepinephrine, it plays a key role in regulating our mood, our energy levels, our stress response. So it can also work with our energy and our alertness, right? So if we have low norepinephrine, it's been hypothesized to be linked to fatigue, low motivation, and even difficulty concentrating, which we see with depression sometimes. Norepinephrine helps our body respond to stress, but if we have too much norepinephrine, it can contribute to anxiety and even agitation. On the other hand, if we have low levels of norepinephrine, it's associated with symptoms of depression. Like I mentioned, the low energy, the lack of interest in activities. And serotonin also helps with our mood regulation. So serotonin is the happy hormone. It's associated with calmness. So first generations typically target norepinephrine and serotonin. Then we have the TCAs. So these are the tricyclic antidepressants. And here are some of the examples. So we have nortriptyline, amitriptyline. And with the first generation tricyclic antidepressants, the adverse effects are those cholinergic effects, right? So the blurred vision, the dry mouth, the constipation, urinary retention, even impotence. And for this reason, there is typically a non-adherence to the treatment because of these adverse effects. So as I previously mentioned, first generation antidepressants are not the first line of treatment anymore. And one of the reasons is because they do have that potential for overdose, which can be lethal. And 70 to 80% of clients that do overdose on first generation antidepressants may die before reaching the hospital. And this is primarily because there are CNS and cardiovascular systems that are mainly affected with the overdose. And death typically does result from seizures or cardiac dysrhythmias. And for this reason, previously people were only given a 1 month supply of first generation antidepressants, specifically the tricyclic antidepressants, because of the risk of suicidal attempts. So if a client does overdose on tricyclic antidepressants, there's no specific antidote. It's really that supportive management that needs to be done. So we can try to use activated charcoal to decrease the drug absorption in the body. We can also try to speed up elimination of the TCAs by alkalizing the urine. So, we can administer sodium bicarbonate, and this is going to speed up the elimination of the tricyclic antidepressants by alkalizing the urine. We can manage any seizures or dysrhythmias and provide basic life support. So the MAOIs is the other category in the first generation antidepressants. These are known as the monoamine oxidase inhibitors. So the way that these work is that they block the action of an enzyme called monoamine oxidase. And typically, monoamine oxidase breaks down serotonin, norepinephrine, and dopamine. So here we're using the monoamine oxidase inhibitors. So it's going to block the action of the MAO, which is that enzyme. Because remember, we don't want norepinephrine, serotonin, and dopamine to be breaking down, because that's what is causing, or hypothesized to be causing, the symptoms of anxiety and depression. So this is not the first line treatment, as I've previously mentioned. The first line treatment for depression is second generation, but you might still see MAOIs, and they're typically used for treatment-resistant depression as well as other mood disorders. And the main disadvantage or concern with using MAOIs is that they have a potential to cause hypertensive crises when it's taken with tyramine. So there are certain foods that include or have tyramine in them. So if clients are taking monoamine oxidase inhibitors and they take foods or drinks that have tyramine, it can lead to a hypertensive crisis, which essentially means that they might have cerebral hemorrhage, they might have a stroke, they might even result in a coma or potentially even death. So monoamine oxidase inhibitors, remember, they block monoamine oxidase, which is that enzyme. And typically monoamine oxidase, so the MAO, that enzyme breaks down tyramine. But if we're using monoamine oxidase inhibitors, this breakdown is not happening. So then the tyramine levels in our body is going to rise, and this is going to result in a sudden increase in our blood pressure, hence the hypertensive crisis, and that can be fatal. So if you do have a client that's taking MAOIs, they have to be instructed and educated to avoid foods that are high in tyramine. So things like aged cheese, cured meats, avocados, and even some alcoholic beverages. So next we have the second generation antidepressants. So from the 1980s up until now, there's been a lot of development in psychiatric medications. So normally, after serotonin is released between nerve cells, it is reabsorbed by the sending neuron. So with SSRIs, selective serotonin reuptake inhibitors, we're blocking this reabsorption, or we're blocking this reuptake. And this is going to allow more serotonin to stay in the brain. And this is going to help with improving our mood and reducing the symptoms of depression and anxiety. So we also have a list of some of the SSRIs, so fluoxetine, paroxetine, citalopram. You may have heard of some of these. But the SSRIs, they have fewer adverse effects than the first generation antidepressants. So they don't have those anticholinergic and sedating adverse effects that might limit the client's adherence to the medication. But of course, they still have adverse effects of their own, such as insomnia, low libido, failure to orgasm, even nausea or vomiting. So still, we have to educate our clients on these adverse effects, because this may be one of the reasons that clients discontinue the medication. So when it comes to teaching our clients about SSRIs, we have to educate them that the therapeutic effects can take 4 to 6 weeks. So with many antidepressants, not just SSRIs, they do take 4 to 6 weeks to take effect. So we have to educate the client that they have to remain consistent. It's not like you have a fever, you take Tylenol or Advil, and then the fever goes away. That's not how SSRIs work. You have to consistently take them in order to feel a therapeutic effect, in order to feel some sort of change in your mood. We have to educate them on the sexual dysfunction, or the insomnia, anxiety, and the nervousness that might happen. We also have to let the clients know that they shouldn't be taking an SSRI within 14 days of the last dose of a MAOI. Sometimes clients are switching between antidepressants, so we have to monitor for that as well. And that's because we're going to talk about something called serotonin withdrawal and serotonin syndrome. No over-the-counter drugs should be taken without first notifying the primary care provider. Sometimes clients that have mental health issues might be taking certain herbal medications. And some herbal medications, such as St. John's wort, for example, they can cause interactions with SSRIs. So always educate the client on providing a full list of all of the medications they're taking, including vitamins, over-the-counter herbal products as well. As we've mentioned, not to drive or operate heavy machinery until drowsiness or dizziness has been ruled out. Clients should also avoid alcohol. Liver and renal function should be performed, and blood counts should be checked periodically for clients taking SSRIs. And the medication should not be discontinued abruptly, and abrupt cessation can lead to serotonin withdrawal. So like I mentioned, sometimes clients start to take an SSRI and Maybe they don't have a full understanding of how long it's going to take to feel the therapeutic effects. They take it for a few days, take it for 1 or 2 weeks, and they don't notice any difference, and then they abruptly stop taking it. This can cause serotonin withdrawal. So these are flu-like symptoms. They might have trouble sleeping. They might experience nausea, poor balance, sensory changes, right? They can even have intrusive thoughts, increased anxiety, increased depression. And this problem can begin within a few days or even a few the problem can the problem can begin within a few days of abruptly withdrawing from their medication, and it can even last several weeks to several months. So very important to educate the client on not abruptly stopping their medications. And of course, we have to educate the clients to report any of the following symptoms when they are first taking their SSRIs. So increase in depression or suicidal thoughts. I'm going to get back to this because I have a specific slide on this. With second generation antidepressants, we also have SNRIs, which are serotonin norepinephrine reuptake inhibitors. So these medications increase both serotonin and norepinephrine levels in the brain. So these are some of the examples of the medications here. We also have serotonin modulators and stimulators, as well as serotonin and norepinephrine disinhibitors. So the medication that we've mentioned here is Remeron. So this can also be used for insomnia that's associated with depression. And Remeron does cause that drowsiness effect, so it can also be used for insomnia, but it does also have the potential for increased weight gain. And these are just some other drugs that can be used to treat depression. So the first one is bupropion. This is effective as a treatment for both depression as well as a smoking cessation aid. So clients that are trying to stop smoking can also be prescribed this medication. It's not just for depression. There's also trazodone. This is not first-line treatment for depression, but you might still see it. It does have antidepressant effects that are usually only seen at high therapeutic doses. Trazodone can also be used for insomnia as well. So wanted to mention serotonin syndrome. So this is associated with the use of SSRIs, so selective serotonin reuptake inhibitors, and it is a rare but life-threatening situation that can happen. So when clients are taking SSRIs, we always are monitoring for symptoms of serotonin syndrome. So serotonin syndrome happens when there's too much serotonin in the brain. And this can happen if we're taking multiple medications that can increase our serotonin levels. So if we're taking SSRIs or monoamine oxidase inhibitors, certain painkillers can also increase serotonin levels in the brain. And even herbal medications like St. John's wort can increase serotonin levels in the brain, which is why we have to ask the client for a full list of all of the meds they're taking. So serotonin syndrome, too much serotonin in the brain. And they might feel symptoms like abdominal pain, diarrhea, sweating, tachycardia, fever. They might even have elevated blood pressure. There might even be seizures or status epilepticus when they have one seizure after another. And although it is rare, it can be life-threatening because the severe manifestations can include that excessive high fever, cardiovascular shock, or even death. So when it does come to the management of serotonin syndrome, we have to immediately discontinue the medication that is causing the serotonin syndrome. And we can initiate symptomatic treatment. So sometimes we might have to give a serotonin antagonist. So this can potentially reverse the effects. We can also give cooling blankets because remember, the client might have a excessively high fever. We can also give the client intravenous fluids to combat any dehydration because of that excessive fever that they have. We can support their vital signs. We might have to give oxygen therapy. We have to, do cardiac monitoring. So monitoring the client's heart rate, their rhythm, their blood pressure. If the client is experiencing agitation and muscle rigidity, we might even have to give them a benzodiazepine, such as diazepam, because the benzodiazepines are going to control the muscle contractions and control the agitation that the client is experiencing. Similarly, we might have to give anticonvulsants to help control that muscle rigidity, especially if they are experiencing seizures. And in severe cases, if the client does have severe hyperthermia, we might even have to give a paralytic agent and intubate the client to really reduce that excessive muscle activity or that heat production. So wanted to specifically talk about the suicide risk with antidepressant drug use. So there is a concern that antidepressants can result in an increased risk of suicidal ideation. However, it's inconclusive or the studies are contradictory, and these events are rare. And when they have been reported, there are inconsistencies on how they're reported. And evidence does suggest that the suicide risk in adults is likely not increased when they take antidepressants. However, some studies do show that there is an increased risk in suicidal ideation for children and adolescents. But still, the studies are inconclusive. Regardless, Health Canada does require that all SSRIs and all SNRIs do have to have a warning for all ages. So there is a warning that these medications do have the potential for an increased suicidal ideation. So for that reason, we do have to educate clients that if they do start to experience thoughts of suicide, even if it's passive, they do have to report it to their primary care team. So that maybe the dose needs to be adjusted or they have to be switched to another antidepressant. So we are going to be talking about suicide risk assessment later. But just for the purpose of where we are in this course now, anytime a client is started on a antidepressant, we do have to do a suicide risk assessment. So when it comes to our nursing process for antidepressants, once again, we are starting with a full head to toe assessment, right? Physical, psychosocial assessment. So we're assessing the client's mood, their affect, their energy levels. Do they have suicidal ideation? Have they experienced any suicidal attempts? How long have they had these depressive symptoms? Are there certain things that make them feel better? Or assessing their sleep, their appetite, their concentration, their social functioning. Because as we're going to learn when we talk about depression, clients might be isolating, they lack motivation, they are experiencing anhedonia, so a lack of interest in activities that they previously used to enjoy. We're also monitoring their vitals, their weight, and even lab work. with depression, as we'll learn about, sometimes clients might feel excessively hungry. Sometimes they might have no appetite, so their weight can fluctuate as well. In terms of the nursing diagnosis, once again, this is just one example. There can be different diagnoses that we think about based on the client situation. So one example is maybe there is ineffective coping related to the symptoms of depression. Or maybe there is a risk for suicide related to the mood disorder. And that's what we have to assess for and we have to plan for. With planning, we want the client to be able to verbalize improved mood within a few weeks. So antidepressants can take 4 to 6 weeks to kick in. So ideally, this should say 4 to 6 weeks. And the client should remain free and safe from self-harm or even suicidal ideation. With our interventions, we are monitoring for suicidal ideation, whether it's passive or even active, right? Especially in the early phases of treatment. We have to teach the client that there is a delayed onset of action. So it is going to take time, 4 to 6 weeks, for the effects to kick in. So be patient, continue to take the medications. Don't abruptly withdraw and stop the medications. We have to educate them about the side effects. And of course, we have to monitor for serotonin syndrome. And for the first generation, the tricyclic antidepressants, we're monitoring for those anticholinergic effects, right? So the blurred vision, the dry mouth, the urinary hesitancy and retention, even orthostatic hypotension. With the monoamine oxidase inhibitors, we're educating them about the tyramine restricted diet because we're trying to prevent that hypertensive crisis. In terms of evaluation, we are hoping that the client reports decreased depressive symptoms. But we're also monitoring for the therapeutic effects of the antidepressants. So does the client report an improvement in their sleep patterns, in their nutrition? Are there improved feelings of self-esteem? Are there decreased feelings of hopelessness? Is there an improvement in the client's appearance? Is there an interest in their self and daily activities? Are there fewer manifestations of depression symptoms or fewer suicidal thoughts or ideations? Does the client demonstrate safe use of the antidepressant? So are they avoiding the contraindicated food and drugs and so on and so forth? So next we're going to learn about mood stabilizing medications. So when we're talking about mood stabilizers, we're really talking about medications that are used to treat symptoms that are associated with bipolar disorder. And as we're going to learn when we learn about mood disorders in a few weeks, with bipolar disorder, they can have extreme mood changes. So they can have periods of extreme depression, and they can have periods of extreme mania where they are experiencing elevated mood. So with this mania, they might experience feeling elated, feeling grandiosity. They might have a flight of ideas. They might even be, they might have difficulty sleeping, or they might not even eat because they feel that they don't need to eat. They don't need to sleep. They're feeling really excited. They're feeling really high on life. So the mood stabilizing medications, the one that we're going to specifically talk about is lithium, and this is the drug of choice for the treatment of mania. So with lithium, there are different type of salts. So you might have lithium carbonate, lithium, and different salt versions of lithium. But in the next couple of slides, we're going to learn about the adverse effects as well as the toxic effects and the low therapeutic index for lithium. But for now, on this slide, we need to know that lithium is a drug of choice for the treatment of mania. So here it's very helpful in managing the elated mood, the grandiosity that the client is experiencing, that mood expansiveness, those flight of ideas, that irritability and the anxiety that the client might experience. So when it comes to lithium, when we say that it has a low therapeutic index, we mean that the dose of this drug that can cause death is not that much greater than the dose that is required for the therapeutic effectiveness. So because there's a low therapeutic index, we have to regularly monitor the lithium levels for the client. So before the client starts lithium, we have to monitor their blood work. And any time that the client has a dose change, we also have to do blood work. And for the duration of the time that the client is taking lithium, we have to monitor their blood work on a monthly basis. So we're monitoring the lithium levels. And it's important to know that the onset of action for lithium is typically 10 to 21 days. So in order for the lithium to work, it has to reach the therapeutic level in the client's blood in order to be effective. So because it can take 10 to 21 days for it to be effective, clients can also be started on antipsychotics during this time. But we'll learn more about that when we talk about mood disorders in a few weeks. So in regards to this low or narrow therapeutic range, what we need to know is that the maintenance serum level for lithium should be between 0.6 and 1.2. If the levels exceed 1.5, so the 2 is really a severe reaction. If it exceeds 1.5, then we are seeing signs of lithium toxicity. So here, the client might experience a lot of symptoms, which I have, I believe, listed on the next slide. So I'll get to that in a moment. So the reason that we need to monitor lithium and sodium levels is because lithium and sodium, they work closely in the body. So if the client's sodium levels drop too low, so say the client has a low salt diet, or for some reason the client is dehydrated, then the body is going to hold on to lithium. So then this is going to increase lithium levels to toxic levels in the body. If the client's sodium levels are going to rise, then the body is going to flush out the lithium too quickly, meaning there's going to be low levels of lithium, and then the drug is not going to be effective. So for this reason, when a client is on lithium, we're monitoring their sodium levels as well as their lithium levels. So the therapeutic or the normal range, once again, for sodium is 135 to 145 millimoles per liter. And we don't want to exceed 1.5 for lithium. So there are, of course, adverse effects to taking lithium. So there's the regular adverse effects that the client might experience, such as a fine hand tremor. They might have polyuria. They might even have polydipsia, so mild thirst. They might experience some nausea and even some general discomfort and weight gain. And long-term lithium use can be linked to hypothyroidism as well. So we also should be monitoring the client's TSH levels, T4, T3. Those are the common adverse effects. Now, lithium toxicity. Here we might see nausea, vomiting, diarrhea, slurred speech. The client might even have these chorioathetotic movements, which are these involuntary wave-like movements of their extremities, so they can't keep their hands still. They might even experience ataxia, which is the loss of full control of their body movements. They might be very confused. There might even be coma and death. So lithium toxicity is a very serious situation, which is why we're monitoring the client's lithium levels. The 4Ds of lithium toxicity risk. So this is what increases a client's risk of lithium toxicity if they're dehydrated. Because remember, if the sodium levels are too low, so this is due to dehydration, then the body is going to hold on to lithium. So then we have increased lithium levels in the body, which is going to result in toxic levels of lithium. If there is decreased sodium, if there is decreased kidney dysfunction, because the kidneys aren't working effectively, they're not able to eliminate sodium or lithium effectively. And other drug interactions can also cause lithium toxicity. In regards to managing lithium toxicity, if we suspect that the client might be experiencing lithium toxicity based on the symptoms, we have to immediately discontinue lithium and notify the physician or the psychiatrist. And if the client is in the hospital, then we can try to enhance the elimination of lithium. So they might be given IV fluids. We have to monitor their electrolytes as well as their kidney function. We can even give them antiemetics for nausea. And there also are safety precautions that we can put into place for the ataxia, so that full loss of body movements, the loss of full control of their body movements, as well as the confusion that they're experiencing. This is a list of other medications that can be used to treat bipolar disorder. So lithium, it does play a central role in the pharmacological management of bipolar disorder. But there are other medications that can also be used. And some of these medications are also used to treat seizures, but they're also useful in treating bipolar disorder. So when it comes to our nursing process for mood stabilizers, we have to know that before we administer lithium, we do have to do a full physical assessment on the client's ability to even tolerate the medication, right? So we're going to be doing a baseline of their labs, right? So their CBCs, electrolytes, their renal, thyroid, liver function. Lithium is contraindicated in pregnancy. So of course, we have to ensure that the client is not pregnant. Do they have a history of seizures? And of course, we're also assessing their mental status, right? So we're assessing their mood, their energy level, their thought processes. In terms of the diagnosis, an example that I have is maybe there's a knowledge deficit for the client that's related to the need for therapeutic monitoring. So as I mentioned, when you're on lithium, you have to do a monthly monitoring of the lithium and sodium levels. So does the client have a good understanding of why they need to do this? Is the client at risk for a fluid imbalance because of the potential for lithium toxicity? That could be another example of the nursing diagnosis for the use of mood stabilizers. For planning, we want to ensure that the client will be able to maintain a stable mood and verbalize, the understanding of monitoring needs. So the blood work monitoring. For interventions, for lithium, remember we want to stay within that therapeutic range, which is between 0.6 to 1.2, because if it gets to 1.5, we have the potential for lithium toxicity. Then we're monitoring for toxicity, monitoring for those adverse effects. We're encouraging hydration and consistent sodium intake. We're also providing teaching about the adherence and avoiding abrupt discontinuation, because that can also disrupt the lithium and sodium levels, which is going to have an impact on the client as well. Evaluation, right? Are we within the therapeutic serum levels? There's no signs of toxicity or serious adverse effects. Does the client report fewer manic and depressive episodes?